So as Professor Shah said, this is going to be an OSCE on hepatobiliary. I mean, I've got plenty of scenarios. We'll see how much we can cover. And Professor Shah has said, whatever we can't, we'll have another day of doing it. Is that right, Professor Shah?
Yes, yes, yes.
Okay. Right. So for a start, my first OSCE is an ultrasound scan. This is presented. The question is, what is seen on this image? What else would you ask the radiologist to provide? What is the likely type of stone? What are the other types of stone, and why do stones form? These are the questions.
Milind is here, so we will read
Right.
this.
Let him read it, and then.
Yes, sir. So this is so this appears to be an ultrasound scan of a gallbladder, sir. It shows a
Yes.
it shows that what I think is a stone because of a posterior acoustic shadow. There is a definitive so it's a mass there with the posterior acoustic shadow. So it's most probably a stone.
What mass in ultrasound? How do you describe this? It's a mass or what?
How do you
hyperechoic space occupying lesion, sir?
And what about the outline you are looking at?
So the wall appears slightly thickened, sir.
Actually, you have to see the thickness. It has to be a measurement. It's not there here, but you can see the gallbladder is distended.
The gallbladder is distended, so there is posterior acoustic shadow.
You cannot say posterior shadow by looking at the picture.
Sorry.
You can say there is acoustic shadow. You can say there is an acoustic shadow. Posterior anterior shadow is while it's a real time. Okay. They put the probe on the back and then get a posterior shadow, and the anterior you get an anterior acoustic shadow. So you say there is an acoustic shadow.
Yes, there's an acoustic shadow, as Professor Shah has said, and the size of the wall, that is also important, isn't it? So you would like the radiologist to tell you, A, what is the sign? It is easier for them to mark it out because they then take 2 points. They've done that. You can see the two plus marks out here. So that will give you a size of the stone. What is normally seen during an ultrasound scan, it is opaque.
The distance is measured 1.87. So you have to look at the picture also.
Yes. It's 1.87. And what you can see is that in an ultrasound scan, you see one side. You don't see the posterior aspect of the stone, but you can see an acoustic shadow because this is eco-opaque. Professor Shah, can I have facilities for annotations?
Yes.
Can somebody start off the annotation? Can share the.
Whoever is joining from ClearNet, can you please allow that? Can you please allow the annotations? It will be easier for sir to mark.
Yes, it will be easier for me to mark. Okay, while they sort it out, Dr. Milind, so, I mean, what else would you have liked the anesthetist to the radiologist to have commented? He's given the size of the stone, fair enough. What else?
The report compact, yes.
So the thickness of the wall.
Yes.
Right. Whether the wall is regular or irregular.
Suspicious?
Sir, thickness more than.
What would be suspicious?
Thickness more than 4 mm.
Yes, thickness more than 4 mm, absolutely right.
So then whether the wall is regular or irregular wall.
Okay, right.
Sir, any pericholecystic collection.
Good. So where would you see that? You would see that as a black mark out here.
Yes, sir.
The common place to see it is which side of the gallbladder?
So it's seen.
It's easier to see it on the hepatic aspect, isn't it? Because you have a duodenum on the other side. It's very difficult to assess that. So it is usually assessed on the hepatic axis aspect of the gallbladder. So if there's acute cholecystitis, you would have seen a blackish mark of fluid. You know, fluid is darker than you see the fluid out here inside the gallbladder. So you would have seen a blackish mark. I don't have annotation. I'm sorry, but I could have marked it out for you. But there we are. That is what you normally see. What is the likely type of this stone? I mean, looking at the stone, what is the likely?
So this looks, since it is so clearly visible, it appears to be
Not clearly visible. It's single stone.
Single stone.
Single stone
Single
is smooth
stone.
outline. So it's likely to be a
yes. Cholesterol stone.
Cholesterol, absolutely. So what are the other types of stones?
There are three types of stones: the cholesterol stone,
Okay, so
the mixed stones, and pigmented stones.
And pigment stones are two types.
So I'm going to point out one. What stone is this, do you think? This on the right side?
Cholesterol stones.
Okay. What stones are these, do you think?
Pigmented stone.
Pigmented. And what stones are these?
So mixed stones?
Yes.
Mixed stones.
Yes. Stones are faceted stones.
Faceted stones. And they often have a inside focus. It's said to be a tombstone erected to the bacteria which is dead inside, isn't it?
Effective focus.
Correct.
Yes, sir.
Yeah. Okay. So why do stones form?
Sir, stones form, sir, because, sir, due to, sir, there are,
broad outline.
Bile gets
no. The broad outline.
Broad outline.
Three important factors for stone formation.
Hypersaturation of bile with cholesterol and infective foci. And thirdly, sir, there is the flow of bile gets
So three factors are alteration in bile composition. Number 2 is infection, and number 3 is biliary stasis. These are three basic factors.
So and this is the triangle. The ratio of the cholesterol with white salts and with phospholipids. Stones normally start forming at the phase 2. And at phase 3, you have stones forming. And as Professor Shah quite rightly said, abnormal functioning of the gallbladder, which is why you have pregnant ladies developing stones, because all the muscles are weak. So the muscles become softer. So the gallbladder becomes softer. It doesn't evacuate all the bile in it. There's a layering between the fresh bile and the bile that is there from before, because it's concentrated. And that is why you have stones forming in pregnancy. As you quite rightly said, and Professor Shah also said, balance in the biliary constants as an obesity, fat-rich diet, female population more prone to gallstone formation, and pregnancy itself, and multiparity. Big altered absorption, because in there's an enterohepatic circulation of bile. So if you have a damage to the terminal ileum and the cecum complex, you have less absorption of bile salts, which actually keep cholesterol in solution. So alteration. And you're absolutely right. Infection, in the presence of infection, there's high luminal levels of tauroxycolate and associated increase of IgG and mucus glycoprotein, and that actually induces stone formation. Professor Shah, do you have any other questions? We can go to the second then.
Yes. Swarup, Dr. Swarup, you're on. No, okay. So just yes.
Good morning, sir.
No, let Milind complete this.
Okay.
What additional information is provided in this image?
And I've put an arrow so that there's something that is shown out here.
What are these two structures seen just below the gallbladder in sonography?
So the next to the gallbladder side should be the bile ducts.
And what remains close to the bile duct? No, portal vein.
Portal vein.
You can see the portal vein and bile duct.
Parallel structures, two double-barrel structures that you see. One is the common bile duct, one is the portal vein. What do you think about the ratio? What is the usual ratio? What is the size beyond which you think the gallbladder, the bile duct is dilated?
Sir, in ultrasound, 5 to 7 mm, sir.
Okay. Similarly, borderline dilated. Is 3 to 5 millimeter is a normal bile duct diameter, and portal vein is little wider than the bile duct.
So you have a double-barrel structure out here with one structure narrower than the other structure.
Yeah.
So the next question I'm going to ask is, that is the importance of the measurements, as Professor Shah quite rightly said. 3 to 5 is the usual size of the bile duct. Portal vein usually varies from 10 to 12. Beyond 12, we think of portal hypertension. So that is the importance of these measurements. Sometimes your radiologist doesn't give these measurements. That's unfortunate. Because how does one predict the presence of polydocylithiasis in a patient with gallstones?
So,
indirect evidence and direct evidence.
sir, if the patient, sir, indirect evidence, we would ask the patient for the history and exam.
No. Ultrasound.
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 So, sir, a dilated CVD, a dilated
Before that,
duct,
dilated
intrahepatic biliary
Yeah,
radicals,
it's not
dilated
Yes.
dilated intrahepatic
Yes.
biliary radicals, and dilated CVD, sir. That would be an indirect evidence. Sir, a direct evidence if we would be able to visualize a stone in the common bile duct, sir.
Okay. There is a beautiful chart, and I'm going to give you that chart. That's from Bloomgut. So the risk classification is high if your bilirubin is more than 2, if the ALK force is more than 150, and a present or recent history of jaundice and pancreatitis. And as Professor Shah quite rightly said, on ultrasound, you have a dilated CVD, intrahepatic bile ducts, and stone on sonography. Now, intermediate is if the bilirubin is 1.5 to 2. I mean, if the situation is high, you have to go for an MRCP plus minus ERCP. We'll come to that in the next few slides that we see. Intermediate bilirubin is 1.5 to 2 milligram. Alkaline phosphatase 10 to 150. The transaminases are more than twice normal. And you have a remote history of jaundice. The patient has had a history of, come in with a history of jaundice, obstructive jaundice, or pancreatitis. Now, you have a situation risk stratification where it's low, where you can have a normal liver function test, no ductal dilatation, no jaundice or pancreatitis. In that situation, you go for a cholecystectomy. In the intermediate variant, personally, a lot of practicing surgeons would opt for an MRCP if you have all these factors, or else at least a per-off intraoperative cholangiogram. Professor Shah, any other questions?
This chart is important because often in the exam will be asked in a patient of chronic cholecystitis or gallstone disease, when you will consider further evaluation for CVD. Because if you see the ultrasound, there is 20 to 30% chance only to miss a CVD stone because of number of factors. Patient is obese, there is gas interface between the bile duct and the duodenum. So they are the situation where you can miss a stone in the bile duct on ultrasonography. Point was, when you consider evaluating the CVD, these are the situations. Some high suspicion features where you should go for a MRCP, or if you add more, it can be a EUS also, and the intermediate suspicion. These two situations, but the last one, if there is low suspicion, there is no role for doing routine MRCP in all patients.
Yes, absolutely. Right. So, who's next? Because I'm going to show you two different patients. They are not the same patient.
Yeah.
Yes, sir. Good morning,
again, a ultrasound.
Sir, this one.
Sir, let's look at the question. What is shown on this image? What is the pathologic classification of the condition, clinical importance, and risk factor of developing a neoplasia? So first is first. What do you look at? What is the area of interest shown in this picture?
So there are two different patients, one on the left, one on the right. So you take it away from there.
Okay, sir.
On the left picture first.
Look at the left picture.
Sir, here the USG of the gallbladder with thickened gallbladder wall, and
there is a classic finding in this. Classic finding, you often find
classic finding.
Give a description. Something hanging from the wall.
Can you see that?
Oh, yes, sir.
What is that described as radiologically? This is a very common situation. You will often find such findings. Yes. These are described as cometal artifacts. What are these actually?
What are these?
What are these actually?
What is that?
Adenomyosis.
Not exactly adenomyosis. These are cholesterol deposits in the wall. These are cholesterol cholesterol deposit in the wall, and classically described this is a cholesterosis of gallbladder, where you can have these cometal artifacts, which is because of the cholesterol deposit in the mucosa, which is hanging inside the lumen. So these are cometal artifacts.
And very characteristic. You mustn't miss that. This is the gallbladder showing cholesterosis. You have little comet tails and big. Why do you have comet tails? Because the cholesterol deposit is so small. Usually when you're using the probe diverges. So you have two rays going on both sides of a very small stone, a very small deposit, as a result of which they form together. So they come together and you have this sort of a comet tail artifact. If we go to the next one, what is characteristic about this?
Describe the picture first. Describe this picture about the gallbladder, its wall, and distensibility.
This is the distant distended gallbladder with thickened wall with some hyperechoic shadows in between.
What are these? They are stones. Last picture you have seen.
There is a reason that I showed this and I showed this side by side.
Last picture you have seen a classic finding, which was diagnostic of stone. Here there is a hyperechoic shadow inside the gallbladder. But do you find an acoustic shadow?
No, sir.
Do you see the acoustic shadow? So what does that tell you immediately? What should be the important thing? The moment you don't see an acoustic shadow, what are you thinking of?
Is it a stone or it's a soft tissue shadow?
It's most likely soft tissue shadow.
What might be the cause for the soft tissue shadow?
It's polyps.
Polyps, yes. So
Polyps,
that is the difference.
Yes.
You will not find a acoustic shadow. Next question is this: what is the clinical importance of this condition? Oh, no, before that, there is what is the pathologic classification of the condition?
What is the pathological classification of this of the lesion on the right side? Image on the left side. On the right side, sorry. How do you classify? So there's a beautiful thing. Gallbladder polyps can be non-neoplastic polyps, can be neoplastic polyps. Non-neoplastic polyps, we've just seen cholesterol polyps and cholesterosis. You've seen that. Okay. You have inflammatory polyps. And you talked of something called adenomyomatosis, where you normally what happens is, I wish I could draw, then I could, you see, there are sinuses. It's called the Rokitansky-Ash of sinuses in the mucosa of the gallbladder, and you have cholesterol deposits out there. That leads to inflammation, sometimes even localized perforation. Now, the problem is, what happens is with adenomyomatosis, that's the only time that we get worried. You have gallbladder wall more than 4 millimeter, and you're always, and it's, part is more than 4 millimeter. It isn't anywhere else. So now the issue is, are we handling an adenomyomatosis or are we handling a carcinoma of the gallbladder? That is the importance of adenomyomatosis in clinical practice. Of course, you have neoplastic polyps where you have adenomas and malignant polyps. Now, the problem is if you have multiple malignant polyps, sometimes you have polyposis of the entire biliary channel. So if you have a situation like that, if you have a situation like that, then it's mandated that you should also, if particularly the alkaline phosphatase is high and bile duct is high, is dilated, you must get an MRCP to see the bile duct, whether there are any polyps in that bile duct. Right?
Yes, sir.
So what are the risk factors? Yes, Professor Shah.
Yeah, there is another question. What is the clinical importance of finding polyp in the gallbladder?
Sir, if the
why are you worried? Why are you worried finding a polyp in the gallbladder? It can be single, it can be multiple, it can be 2 millimeter, 5 millimeter, 10 millimeter.
If the size is more than 10 millimeter, or if there are multiple polyps, or if there are symptomatic polyps, we should go for cholecystectomy because of the
why polyps are important?
Why?
The chance of malignant transformations.
Yes, is a neoplastic is a risk factor for development of gallbladder malignancy. These polyps are
risk factors for gallbladder
likely to undergo change And
change.
size you are talking of 10 millimeter is the borderline where you suspect that
Yes.
it might turn malignant. So clinical importance
So
is
with 58% of large polyps more than 1 centimeter, if you have
multiple polyps.
coexisting PSC,
Yes.
coexisting
primary
PSC,
sclerosing cholangitis.
they have a very high incidence of gallbladder cancer. Forget cancer in the bile duct. If you have PSC coexisting, they have a high incidence, 57% incidence of malignancy in the gallbladder. Also, if you have sessile polyps and the wall thickening is more than 4 millimeters, so the incidence increases 7 times compared to a person who has a pedunculated polyp. And this has come out in literature as well. If you have Indian ethnicity, particularly if you have somebody living along the Gangetic Plains, the incidence is 5.5% versus 0.8%. So the other thing that hasn't been established, age above 50 years, if you have a patient who's aged about 50 years, the things that haven't been established, coexisting gallstones, is very difficult because there's possibly a low risk and of course adenomyomatosis we just described. Professor, any other question? We'll move on to the next one then.
Yes. And the last question is, there is another question in this. OSCE 3, there is another question, I think.
Yes.
Oh, you have answered that. What are the...
Yeah, they've answered that.
Yeah. So these are the things, you see, in OSCE, you have specific questions. So you have to answer to the point.
And not, this is not a theory paper. So you have to write in short. That is the most important thing.
Yeah. Okay. I think Nitesh, you will come. Nitesh. Yeah.
Right, Nitesh, why don't you read this out?
Read.
Sir, a 62-year-old who presents with fever, with pale stool and high colored urine. What does
the image show and what procedure has been done? You keep in mind, you see both the picture. Okay, you have to give a complete answer. What is the procedure and what has been done? Tell me.
So the first picture shows.
What is the procedure?
Sir, the first picture shows,
is it a diagnostic ERCP or?
Sir, it is a therapeutic ERCP.
Yes.
Therapeutic ERCP,
yes.
sir.
Yes. So
this is not an MRCP. So that is
from.
Yeah. And the second picture shows, sir, the ERCP with stent placements.
What stent it is?
What it is?
Stent?
You see, there are two bend on either side. What is the next side does? If you one side bend, that is J. Yes, and two side bend is double J stent.
Double J stent. So you have J's on both sides. One J out here, one J out here. That's to ensure
so how
that
do you describe the first picture?
First picture, sir. So there's CVD.
Always start with IHBR. You see?
Yes, sir. IHBR, sir, is not.
It is dilated. How do you say dilated? If in a picture, if you find, you can see the two parallel walls. These are dilated IHBR. If you find a only hairline, that is a normal IHBR. You see, there are two parallel lines. Yes. Okay, this indicates the IHBR dilatation. What about the CBD?
Distal CBD is significantly.
How can you make an estimate about the diameter of CBD looking at the picture? There's no measurement here.
Can you find out where
what?
So CBD is supraduodenal.
No. I'm saying I'm looking at the CBD.
No.
I make an estimate. Yes, this might be the diameter, but there is no scale.
So from here to here.
Yes.
Can you use something as a reference point?
What is the diameter of the scope? The scope is inside.
You have the scope. See, that's a scope
inside. Is 13 millimeter. Scope is 13 millimeter. If you find that the diameter of the bile duct is more than the scope, it is likely that it is at least more than 13 millimeter. Otherwise, you can measure. In digital X-ray, there will be a dimension written in the X-ray plate. So you measure and go with the dimension given in the digital X-ray plate. It may not be real time. You see, if in the digital X-ray, as it is made in the computer, it may not be exactly same as the exact diameter.
But as Professor Shah quite rightly said, you have the scope just beside the bile duct. So that's a easy 13. That is, I mean, you have the scope. You know the size of the scope, isn't it?
Yes, sir.
So what are you looking at? Is it a normal picture?
No, sir. This is there is stone, single stone in the CVD. This is a case of colloidocolitis.
So how is this filling defect? Is it a regular filling defect or is a round?
Look at the filling defect.
So it is round.
It's not exactly round. It need not be. A stone in the bile duct, maybe a facet stone, or can be a elongated stone like. Okay. So next question is, how would the patient present and how is the condition classified? What are the typical presentation of a patient who is having colloidocolitis? Some part is described.
Sir, patient present with jaundice, sir.
Stage, Harcourt Strat.
Harcourt Strat.
Yes, sir.
You got all the answers in that question itself, isn't it?
Yeah.
Sir, abdominal pain, fever, and sir,
intermittent pain, intermittent fever, intermittent jaundice is a classic. Yes, what is Reynolds pain?
Sir, associated with sir CNS symptoms and sir shock, hypertension.
So this is indicative of what?
Shock. Yeah.
Apart from this, patient has some CNS symptom and shock. Indicative of what?
Sir, cholangitis, sir.
Yes. Indicative of?
Cholangitis.
Sepsis.
Sepsis. So essentially, how would you classify? We have the Tokyo 2013-2018 guidelines. So the diagnostic criteria, as Professor Shah quite rightly said, is severe inflammation, a fever with chills and rigors, lab findings of an acute inflammatory response. You have cholestasis with jaundice and a corroborating lab paper. And on imaging, you see a dilated biliary tree more than 7 millimeter, and we often find the etiological cause of imaging. Like you see the etiological cause out here. Okay. So basically, management depends on the classification. And again, the Tokyo guideline says it might be mild, no criteria for grade 2 or grade 3 cholangitis, moderate where your white cell count is elevated more than 12,000, patient has a fever more than 39 degrees Celsius, age more than 75 years, bilirubin more than 5, albumin less than 2.5. When you have that and you have dysfunction with shock requiring support, mental clouding, that's what Professor Shah was just asking you, and you have pulmonary, hepatic, renal, or coagulation failure, that makes it a severe cholangitis. How would you manage this patient?
So these are the questions. Dr. Devakshi has not put this question, but this is an important question. What are the Tokyo grading for colloidocolitis? And then next question come automatically. What is the management? Again, it will be as per Tokyo guideline. How?
Grade 1, sir. Grade 1, sir. Sir, patient will be managed conservatively and present 24 to 48 hours before developing the symptoms. Sir, we can go for.
Tokyo guideline is Tokyo guideline. You cannot quote yourself. Tokyo guideline says grade 1 is resuscitation followed by cholecystectomy.
Yes,
but point is, if it is beyond 72 hours, it is going to be difficult cholecystectomy. Okay, but the recommendation is resuscitation followed by cholecystectomy. And you need definitely an experienced person to do this procedure. What about grade 2?
Sir, resuscitation. Sir,
again, recommendation is resuscitation followed by cholecystectomy. But this is going to be more difficult.
Yes.
Okay, you may end up doing a subtotal cholecystectomy. Okay.
Yes. And also we need the drainage of the bile duct. We might need to drain the bile duct process before we go in for the procedure, isn't it?
Yeah.
Yes.
Yeah.
I mean, that is what is being shown out here.
Yes, sir.
Get it?
Yes, sir.
What about severe?
Sir, resuscitation followed by sir biliary drainage by either by sir ERCP.
Or suppose it's a situation where gallbladder is at fault, there is more of pus collection in the gallbladder, and also patient has got a CBD stone. ERC may fail in this situation sometimes.
Sir, percutaneous
Yes.
drainage of sir.
So it can be first of all is a resuscitation. You see, these are the patient who has shock organ dysfunction.
Yes, sir.
So this patient cannot be taken up for surgery till the organ dysfunction is corrected.
Yes. So first is resuscitation, always resuscitation. Then next is drainage of the biliary tree.
Yeah.
Now that can be by a choledochal drainage, a nasobiliary drainage, or an ERCP with a stent put in. But that's important because this is a dire emergency. Patients die from severe cholangitis, particularly in that moderate and moderate going on to severe sort of a condition. And then once the patient is settled, then you would address the problem of the stone in the bile duct. This patient already has had surgery. So I have another question for Professor Shah. Bilirubin metabolism.
Yeah. Yes. Just describe before Dr. Debakshi shows the answer. How is the bilirubin metabolized in the body? Where from it forms, how it goes?
So bilirubin is formed by breakdown of sir RBCs. Sir,
What happens? RBC
What
breakdown,
happens?
it gives rise to
sir,
heme and globin.
Where is it broken down?
Heme is what?
Sir, it will reabsorb. Sir, it will be sir, stored.
No, sorry.
Tell us the exact flow of this
Sequence of
formation and circulation.
Bilirubin, sir.
Professor,
Sir,
Yes.
I think I'll show that picture
Okay.
because see, it goes to the spleen. In the spleen, what happens is hemoglobin is broken down to ferric iron, which needs transferrin to transfer to the bone marrow. What happens to the biliverdin and the bilirubin that is formed? It is insoluble. It's still unconjugated. So how does it travel to the liver? It travels to the liver with albumin. Okay, so the albumin carries it, piggybacks it. So out here you have unconjugated bilirubin being taken up by the hepatocytes. Sometimes you have a problem in its uptake. Do you know of any syndromes? A mild one and a severe one?
Sir, Krigler, Nazer, and sir, Gilbert, sir.
Okay, Gilbert's is the mild version. Krigler-Najar 1 is reasonably mild, but Krigler-Najar 2 is very severe. It's incompatible with life. Then what happens? This unconjugated bilirubin gets conjugated inside the hepatocytes and they are liberated into the biliary canaliculi. And that travels down into the intestine. Now, once it travels into the intestine, it goes up to the cecum where, because of bacterial work, it's broken down and a large proportion is absorbed. So that is your intrahepatic circulation. A bit actually travels through as stercobilinogen and it lends to its yellow color. A bit that is reabsorbed, only a small amount, is again excreted through the kidney as urobilinogen. So that is the thing that you need to follow. You have sometimes problem with conjugated bilirubin secretion. So do you have conjugated hyperbilirubinemia?
Sir.
Do you know of syndromes with the name with conjugated hyperbilirubinemia?
When conjugated hyperbilirubinemia occurs.
Yes. Sir, doing
So conjugated hyperbilirubinemia occur beyond hepatocytes.
Syndrome.
It can be intrahepatic also. If you have intrahepatic cholestasis also, you may have conjugated hyperbilirubinemia.
Yes. So when you test it,
sir, in case of primary sclerosing
cholangitis. Yes.
Yes. Now the issue is, I have another small question. Conjugated bilirubin is called direct or indirect?
Sir, Conjugated is, sir, indirect.
Direct.
Direct. Sir, sorry, sir. Direct.
It's direct. You know why it is called direct? Why is conjugated bilirubin called direct? And why is unconjugated bilirubin called indirect? These are basic things you need to know that.
Sir, carrying
some test procedure.
The test that is done, sir, the direct bilirubin is directly visible on sedimentation, and indirect we have to see it through
it's not sedimentation, it is colored, it is Vandenberg reaction. So the conjugated bilirubin, you test first the sample for soluble bilirubin, and that gives you the direct answer, that is direct bilirubin. Then you put in alcohol and you dissolve the entire amount of bilirubin and you get the total bilirubin. The indirect, the unconjugated bilirubin is calculated by subtracting the direct bilirubin from the total bilirubin, which is why conjugated bilirubin is called direct and unconjugated is called indirect, because you cannot measure unconjugated bilirubin.
So it is detected by direct Vandenberg reaction.
Okay, this is basics. You need to know that. Okay, so what would you do for this patient? I'm just going to show up. What do you think is being done?
So mild and moderate, you can go for immediate intervention.
Yes.
In severe, resuscitation followed by drainage.
Yes.
So what is that tube do you think we are using? Nowadays, we use a cholangioscope or a flexible ureteroscope. What is that? What is that balloon-like thing that we are using?
What is that? This is a laparoscopic procedure, you understand?
Yes.
And what are they introduced? Or okay, if they didn't, how can you retract the stone from the bile duct?
See, we are.
What is this? What is this balloon?
See, we are inflating the balloon and pulling it out.
Yes, sir.
This is?
What is that tube?
Used in vascular surgery.
Fogarty.
Fogarty, yes.
Suppose there is a general question. What are the different ways you can use CBD stone while doing laparoscopic surgery? First is you do a colloidectomy.
Yes, sir.
And how do you extract the stone?
So by flushing.
One is the stone on colloidectomy, stone can just pop out.
Yes.
Number one. Number two is not coming out. What you can do?
Irrigation.
You can do irrigation. Okay.
Yes.
You can use milking. You can use two instruments and start milking the stone. But sometimes it's difficult. So irrigation, milking, what else? Stone.
Sir,
Either a Fogarty balloon catheter or coloscope will come next. Next, Fogarty balloon. Next is?
So we can use for irrigation.
हाँ तो irrigation हो गया ना? Irrigation हो गया, Fogarty balloon हो गया. Then you can use a Dormia basket catheter straightway, or you use the coloscope.
Yes, sir.
Or you can use a coloscope, or some people use rigid ureteroscope.
Yes, sir.
You can use a rigid ureteroscope through which you can irrigate and pass a Dormia basket catheter and extract the stone.
So now you've taken the stone out, and Professor Shah beautifully described it. What are you going to do next?
And now you have a large opening in the bile duct. What are the options to manage this bile duct opening?
Sir, we can put T-tube.
Before that, talk of some sensible things. Why do you jump to T-tube? I ask you, what are the options? Option maybe?
Don't forget this.
Sir,
There's something out here. So I think that is something that you need to keep in. We are talking about the same patient.
Yes, sir.
Yes.
Sir, yes,
One option is, you are doing surgery.
Yes.
You have done a colloidectomy.
Yes.
One option may be primary closure.
Yes.
Because this patient already has a sphincterotomy done. You have done a complete clearance. You have done colloidoscopy, no obstruction. One option is primary closure. And while doing primary closure, some people may prefer to put internal stent. Okay?
Yes.
But if you already have a sphincterotomy done, internal stent may not be required. Primary closure. Second is
The T-tube placement.
closure over a
T-tube.
closure over a T-tube. Third option is
T-tube.
doing a bilioenteric bypass.
Bilioenteric bypass.
So there are three options. When you consider doing a biliary bypass?
Sir, if CVD is dilated more than once.
More than 15 mm.
15
And
millimeter.
particularly when there is a distal obstruction.
Distal
If you can
obstruction
document
or even
distal
multiple
obstruction, you have
stones.
to do a biliary bypass.
Yes. Okay. So if I give you the guidelines, the British Society of Gastroenterology, to reduce the incidence of post-ERCP pancreatitis, rectal diclofenac indomethacin is given. Adjunct to endoscopic sphincteroscopy is a balloon dilatation. Cholangioscopy, guided electrohydraulic lithotripsy and laser lithotripsy may be needed. But if you have a difficult stone, and that is what Dr. Professor Shah is talking about, you do a laparoscopic duct exploration, or you can have a biliary drainage with sphincterotomy and a mechanical lithotripsy or cholangioscopy are necessary and highly successful in recruiting common bile duct stones. And it is recommended that percutaneous radiological stone extraction, open duct exploration, should be reserved for a small number of patients in whom most techniques fail. They have a very, in Britain, they have a very strong endoscopic, medical endoscopic setup. So what you will need to do in India is, as Professor Shah quite rightly said, we are now moving off to doing it laparoscopically, extracting the stones. And treatment is primary closure, T-tube drainage, and or else choledocho enterostomy.
A little point about cholangioscopy. What is the idea about cholangioscopy? What is cholangioscopy if you define? This is a newer intervention added. Cholangioscopy is a direct visualization of the bile duct. How is it done? Do you know any concept about how cholangioscopy is done? You need to go inside the bile duct. This scope is not going to the bile duct. The scope you have seen, a standard ERCP scope, will not go into the bile duct. So how is it possible to go inside the bile duct with the endoscope? What is the endoscope? This is described as a baby endoscope. This baby endoscope goes through the channel of the ERCP scope. And through the ampulla, you take the scope inside the bile duct. This is a newer innovation, where you can directly take the scope into the bile duct and see the interior of the bile duct. So the biopsy of the bile duct lesions, stone extraction become more easier cholangioscopic. But you have to understand that is a very delicate endoscope, which is going to the main channel of the main endoscope. This is cholangioscopy. You need a baby endoscope, which will pass through the main endoscope. You can go to the next scenario.
Okay. So that's for the mother and baby.
Yeah. Onkar Nath will present the next.
A patient of 45 years presented with progressive jaundice 2 months after difficult cholecystectomy. An MRCP done shows this.
If I have not shown this, what will be appearing this picture is from? Is it ERCP or MRCP?
It is an MRCP.
Why MRCP?
Why
not ERCP?
Sir, in MRCP,
looking at what you will find that this is not an ERCP.
Sir, in ERCP there will be presence of endoscope.
Yes. So in ERCP you will find there will be endoscope, and if you see the density, if you do a ERCP, you will find that distal CBD will appear more dense than the peripheral IHBRs. You see here the whole biliary tree is appearing as same density. So looking at this, and you can see the pancreatic duct also very clearly here.
Yes.
So it may be that you ask the first question is, what is this study being done? What contrast has been used for this study?
What contrast do you use?
Bile act as a contrasting.
Yes. So in MRCP, there is no contrast being. That is a very important question. Many people ask. No contrast is required for a MRCP, and this is what? T1 weighted image or T2 weighted image?
T2 weighted.
Yes. In T2 weighted image, the fluid becomes white.
Right.
The fluid appears opaque. So it's a T2 weighted image. And is it a real-time picture, while patient is gantry, or is some form of reconstruction?
Reconstruct.
Is using a
Yes, it's
software.
reconstructed. Software, yes.
Initially, patient goes to the gantry, and in the MR scanner, they take axial cuts. And using a software that reconstruct the picture of the bile duct and the pancreatic duct area. This gives you the picture. So that is the specialty of MRCP. It's a non-invasive test. No contrast is required. So what is the defect shown? Dr. Demoksha has given you the background of this patient. So what is the...
Pancreatic duct is shown here. It is dilated, sir.
No, it's not dilated. Pancreatic duct is looking normal. It's not dilated pancreatic.
Pancreatic duct is not dilated.
Intrahepatic biliary radicals are dilated.
Yes. What you
Yes.
find? Is it a normal biliarity you are looking at, or
Not normal.
what? In view of a past history of cholecystectomy, what do you think of what has happened in this patient?
There is a filling defect here.
No filling defect. It's a
No.
normal narrowing.
There's no filling defect.
You see, this biliarity, you see these hepatic ducts and this distal bile duct. Do you think these are same, or the upper tree is more dilated?
Upper tree.
Now I've blown it up. Now you can see it better.
The upper tree is more dilated. And what has happened near the region of confluence? Do you find the continuity?
No, sir.
Look at this.
Huh?
Is it continuous?
No, sir.
No. So, you see, background of cholecystectomy and finding this with the area dilated, confluence area is not seen being continuous distal bile duct. What has gone wrong? Suppose it is down the line 3 months beyond the cholecystectomy, 2 months. So, what has happened?
What has happened?
Yes. It's a benign biliary stricture. On the background
benign
of
biliary
cholecystectomy,
stricture.
it should be a benign biliary stricture. And defect shown is what? There is discontinuity of the biliary tree at the region of what? At the region of almost to the confluence. You see, almost two ducts appear separate.
Separate.
How do you classify the defect? How is this biliary stricture classified based on what?
I'm just going to blow it up once again, Professor Shah. You
Yes.
see, that is the left duct. Can you see that left duct? This is the right duct. The right anterior and the right posterior are completely separate. The right posterior is draining separately. Right anterior is joining the left duct and entering the that area of narrowing. So there is a complete disruption in the confluence. That is what Professor Shah was trying to tell you.
So
how
this
do you
classification goes by what name? When you classify biliary stricture based on the extent of the normal looking biliary tree, is goes by Bismuth classification. So where do you place this patient? What is Bismuth 1?
Stricture at the CBD.
Where?
Bismuth 1.
Where?
Where?
Bismuth 1 is you have more than 2 centimeters of the bile duct available beyond the confluence.
Beyond
more than 2 centimeters.
confluence.
Bismuth 2 is? Bismuth 2 is?
The common hepatic duct.
What? Common duct? Less than? You have to say the dimension. Less than
2 centimeters.
Less than 2 centimeters below the confluence. Bismuth 3 is?
Stricture at the level of
At the level of confluence. But both the ducts will be confluencing at the common place. So
Common
there is
place.
a
That is very
up to
important.
the confluence, but the 2 ducts are draining into the confluence. And if it is like this, when the 2 ducts are separated, this is Bismuth 4. This is another classification. What is that? Bismuth is this 1 to 4. And if you talk of bile duct injury, you have another classification. Strasbourg
classification. So you have an ABC added to the bismuth, which is E1 to E5.
Yes.
Now, the importance that Professor Shah was trying to tell you, what is the problem out here? If you look at the blood supply of the bile duct, see what happens. The bile duct has two supplies. I mean, gets its blood supply from various sources. There's a channel at 3 o'clock and 9 o'clock, which runs parallel to the bile duct. But the thing that we normally forget, there's a hilar marginal artery. So can you imagine that if that is spoiled, you don't have a communication between the right and left. And God forbid, if you have a if you have an injury to the right hepatic artery as well, so that there's no blood supply. You don't have a blood supply crossing from left to the right if that is completely damaged. And then what you have is the damage extends. So these are the people who fail. If you do an early repair, then you later find that the patient comes in with a stricture. Why is it? Because you see the right posterior and the right anterior completely separate. So that marginal artery is almost certainly damaged. So here you have to wait, and a delayed repair is best. Professor Shah?
Yeah, I think it's 9 o'clock. No, 5 minutes more.
No, it's 9 o'clock.
Okay, the next question was
then,
how are going to
I'll
manage?
just outline
Yeah.
this algorithm which I've made.
You
Bile duct
will
injury,
ERCP.
it's recognized at the time of surgery.
You are ERCP.
Yes, stenting.
No, how can you do that? You have to assess the MRC picture. If you find there is a
exactly.
complete cutoff, if there is a complete discontinuity, unnecessary, you cannot do intervention which will lead to, you see, if it's a complete cutoff, without being seen a continuity, attempting ERCP is not desirable in this patient. He will end up with other complications. If you have a continuity, there is a narrowing at one point, you can try stenting. But 2 months down the line, it is difficult to do a stenting on the background of fibrosis and the stricture. So how these patients should be managed? How they present actually? How this patient presents?
Present with features of obstructive jaundice.
Yes. So they will present with obstructive jaundice. And obstructive jaundice is what? Just jaundice, pruritus, pale stool. What else may happen with that? Features of sepsis, cholangitis. And if you are not treating, they are going around for 1, 2, 3, 4 years. What can happen?
What will happen then?
Biliary obstruction not being treated, going on for 6 months, 1 year, 2 years. What will happen? What is it called as? You have not heard of secondary biliary cirrhosis. So patient will have developed secondary biliary cirrhosis.
Biliary cirrhosis.
So there are the situations where even you do the surgery, patient may not be optimized at the end of surgery. So a timely intervention and timely drainage is important. Okay, what surgery you plan for this patient? Don't say ERCP if you have a complete cutoff. ERCP has its own complications. So it will be a biliary enteric drainage. Suppose you find 2 ducts are separate. How are you going to manage? 2 ducts are separate. No confluence is not there. What should be the exact operative technique? What is recommended?
That is why I've made this enlarged. You can see that the 2 ducts are completely separate. How would you?
What are the options? You don't know. The options are you can join these 2 ducts.
Yes.
You can join
cholecystoplasty and then
cholecystoplasty and then drain into a single loop of jejunum. Alternatively, if you cannot bring these 2 closer, you have to do 2 anastomosis. This Roux-en-Y hepatogenectomy with the left duct and the right duct.
Yes.
Okay. So either you oppose the 2 duct and do a single stoma hepaticojejunostomy, or you do a 2 separate duct anastomy to the same loop of jejunum.
Yes. And it's a Roux-en-Y hepaticojejunostomy.
Yeah.
So just to finish up, Professor Shah, bile duct injury recognized at the time of surgery. So you have no vascular injury and expertise available. So you go in for, you can go in for a Roux-en-Y hepaticojejunostomy or a bile duct plasty. If you're having to use energy devices to divide the bile duct, you can do a bile duct plasty. If there is vascular injury and expertise is not available, you're better off putting in a drain without furthering damage and refer. I mean, this patient actually, unfortunately, had an attempt, and that is why he had such a major problem. Delayed presentation, that was what Professor Shah was saying. In the immediate post-op, you have a bilious drainage with peritonitis and biloma. You drain without further damage and refer to a center which can do this thing far more adeptly. And if you have a bile duct stricture, of course, there is a scope for endoscopic therapy, never in a situation like that where there's a complete cutoff. You can do it if it's narrowed. You can do endoscopic therapy. Then the treatment is putting in multiple stents, so you gradually dilate it over the stent. Or you can, similar thing, you can do a transhepatic stenting, only and only if there's narrowing with continuity of the bile duct. But if you have a discontinuous bile duct, you go in for a delayed Roux-en-Y hepatic vaginostomy.
Yes. देखो कोई chat box में question है क्या? There are some question in the chat box. We just take this few.
There's been answers, Professor Shah.
Yeah.
Double J, ERCP stenting, GB
Okay.
Polyps.
Okay.
So there have been answers coming.
Okay.
So I think it's 9 o'clock.
Yes. We can take another day. We'll decide about another date. Okay.
Yes.
We can go for liver anatomy and something on the liver resection or this is a colorectal cyst. I think we can take for the next day.
Okay. Right.
Thank you.
Thank you.
It was nice, nice session. Because
Thank
this
you.
is how,
Thank you very much.
This is how the question comes in DNB or OSCE.
So this is about questions.
Complete cutoff, you will find there is a bile duct is not empty. When there is a complete cutoff, distal bile duct may have some mucus secretion. You cannot say this is bile. Got my point?
Yes.
If there is a distal cutoff, the bile duct may not contain bile. It can contain some mucus secreted by the bile duct wall. So if you will find there is a continuity, if you see the picture nicely, find there is a continuity between the walls and there is a narrowing, you can say it's a stricture. The picture has to be interpreted very well to say there is a complete cutoff. This happens. If you ligate the bile duct circumferentially, it is a complete cutoff.
So as Professor Shah said, it's not bile. Any fluid in that distal bile duct will show up white. Don't forget, we are not using contrast. We are just doing a T2 weighted image where any fluid becomes white. That's the criteria. So it might be mucus because bile duct has a capacity for secreting some mucus.
Okay. If there is no other question, close today.
Okay. Thank you.
Thank you.